now is covered because the leaves are starting to fall. So
All right, all right. Okay, I guess we will just take it up from there. If you're joining us, just say hello in the chat section, and we would start in a minute or so. All right, Dr. Reeves. I just want to give a little bit of introduction here. Dr. Reeves is a retired periodontist, a current mentor to new doctors who are undergoing residency, a major force in our hospital where we work, and he has served in the military. He has served presidency, pretty much experienced everything you need to know, about dental implants. You are going to get that knowledge today. It's a privilege, Dr. David Reeves, to have you. I want to call you a professor because that's whom I think you are. Thank you
yeah,
for
that's
your.
actually one of my titles. So
Uh,
yeah,
all right. Thank you for your willingness to
sure.
participate in this today. Please do take it away,
Well,
sir.
very good. So thanks for the introduction. Yeah, I've been doing implants now for about 31 years, so I've seen a lot come and go. What we're going to talk about today are basically some things that are important when you place implants and things to consider when you're placing implants that will make them more successful. So the main thing we're going to see today is that the implant itself is not like the regular tooth. Okay, it's not the same as a regular tooth. It doesn't have a periodontal ligament. It doesn't have a connective tissue attachment. We're going to mention that. But when you talk about what we go for, and that's osseointegration, that's essentially the direct contact at the light microscopic level between bone and the implant. Now, that doesn't mean it has a exact, true, chemical bond. What it does mean is that it does have a close enough approximation that makes it very successful. There's always a titanium oxide layer that exists between those, the bone and the actual implant, but it works very nicely for us. And implants have been around a long time. You can go back to some of the ancient Egyptian studies and see some of the skulls and so forth, and you can see that they've tried all different kinds of stuff. We went through things like gold. We went through like donating a tooth to someone else. We've tried that. We tried platinum as one of the sources or materials for the dental implant. Vitalium was another one. But not until we got to actually titanium did we have much success. And this was first talked about and actually invented by an orthopedic surgeon. And I soon am going to have my shoulder replaced. So I appreciate orthopedic surgeons a lot right now. But what he discerned was that if this works for the body and other types of joint replacements, why not use it in the mouth? And that's what he did. So there's different types of implants. They've been around, like I said, a long period of time. We have the blade type of implant, which looks something like this. Not too successful, unfortunately. And why not? Well, because when you try to place a blade implant, what you essentially do is you take a handpiece and with that handpiece, you make a trough in the bone. And as you do that, you place then this blade implant into the bone and you hope that it integrates. Well, something to think about is that we don't like to raise the temperature of bone too high. And we'll mention an article in a few minutes of why these blade implants weren't so successful. One is they didn't have an intimate attachment to the bone. Two is there's a good chance that when preparing that sort of osteotomy, that what you've had is a little bit of bone necrosis because of the temperature increase using some sort of a handpiece. But you may see a couple of these still hanging around. They're not real popular at all today. Another one that they came out with was what about this? A transosseous or a staple implant. And originally, when implants came around in the 80s, oral surgeons would say, oh, we need to have bicortical stabilization. And what that meant is that they wanted to stabilize the implant both at the crestal cortical bone, but also at the inferior border of the mandible bone. So they said, well, let's do this implant. We'll go in from the bottom and we'll put the screws all the way through the mandible and then we'll attach it to that mandible. And then we can put some abutments in the actual mouth and we can make a bridge. Hey, well, it works pretty well, but you can see that with this sort of procedure, this is an OR procedure, not one that we would do in our regular chairs in a dental office. So not so popular, but does function as long as they're using the right equipment, titanium, etc. Then there were some periosteal implants. These were implants where you actually reflected the tissue of a totally edentulous mandible. You captured an impression of the bone after the flaps had been reflected. You fabricate a framework that is much made like you see here. You go back after the framework has been fabricated. You reopen the patient. You place this framework and hope that it fits really nicely and snugly. And then you cover it back up with soft tissues. But this was not an osseo-integrated implant, once again. Now, I have seen some of these still in existence today. In fact, I treated a patient, oh, probably 10 years ago, and she was in her 80s, but she had one of these that was still functioning. So interesting that we can see that the different transition, but not till we got to this one, this original machined titanium implant, did we have much success in integrating with the actual osseous or bone tissue. And you can see here that that was a polished or machine surfaced in the beginning. And we thought, oh, we mustn't ever scratch the surface of that implant because roughing it will make it not uh, adhere to the bone as well. Well, over the years, we've had evolution, haven't we? And we've evolutionized into an almost fully treated surface. There's some that have, a machine surface at the top, and then have the apical two-thirds of it as a machined or surface treated implant. They're treated by different things, different techniques. Some of them are trademarked, some of them are not. But most of them involve some kind of an etching of that lower area to make more surface area for the osteoblast to integrate into those areas, the fibroblasts first, then eventually the osteoblasts as well. So depending upon which company you purchase from, they can give you the implant with their type of treated surface. Rarely do we see many of the original Nobel Pharma implants or Brandomark implants because we had pretty good success with these new types of implants, which integrate very, very well. And they integrate much quicker than they used to with the machine surface. Now, the machine surface still works really nicely, but these treated surfaces work even better. Now, you all know this. This is something that's not new. You have the prosthetic crown that goes over the abutment. The abutment is attached through a screw generally into the implant fixture itself. And when we look at the different types of attachments, we can see that yes, we do have bone. We do not have connective tissue attachment onto the implant surface, but there are connective tissue fibers that encircle it to help with maintaining the soft tissue around there. You do see, though, that there is a junctional epithelial adhesion or attachment, and there's a sulcus depth around each implant. Funny that it's very similar in that dimension of what we call the biologic width or the biologic dimension for either a tooth or an implant, both of them being around 2 to 3 millimeters. When we look at kind of the biology of those tissues around the implant, it's interesting. We have that junctional epithelium. We truly don't have what we call gingiva. We have perimucosal tissue. We do have that supracrustal connective tissue that surrounds the implant, but never do we have connective tissue that embeds into that implant surface itself. Lastly, you can see that we really want an ankylosing type of implant. We want one that's very firmly attached to the bone, much the opposite than what we want for natural teeth. Because if a tooth is ankylosed and we have to remove that tooth, It's a challenge. We usually have to do a lot of cutting of the bone to get that tooth out. The tooth itself, will have a periodontal ligament. Of course, that's one of my favorite parts is the PDL. Being a periodontist, I understand a lot about the PDL and how valuable it is in most situations. So here's another section you can see. There's our BW, which stands for biologic width. It's very similar in the total amount for both the natural tooth and for the implant. But you can see that with the natural tooth, you actually have connective tissue fibers that have embedded into the tooth structure via the Sharpie's fibers that we know that remain on the tooth, the cementum, etc. But you see with the implant, you don't have that, and that's what we would understand. We also know that with each patient and each different location, the bone varies in density. There's an original article that was done many, many years ago now by Brandemark and Zarb that basically showed there's four different types of jawbone anatomy. When we look at the different types, we would see that there are some areas that are very homogeneous. Cortical bone, that bone we might find in the symphysis area of the jawbone and the mandible. And it makes it so that we have to drill with very sharp drills, or we may end up burning the bone. We actually like the type 2 the best, where we have some cortical bone that provides the stabilization for the implant, but yet we have cancellous or marrow cavity, which then will facilitate the osseointegration. Now, that's not to say that if you have all cortical bone, that you won't get osseointegration, but basically the type 2 is our preferential type of bone quality. When we start to see more of the 3 and 4, we know that we have to think about maybe letting those implants integrate for longer periods of time. And those would be found mostly in the posterior maxilla and patients that have very poor density. So looking at those things, we have to think about a lot of different things and considerations before we go in and place the implant. The bone quality. We have to know about the implant itself and what's the differences. We also have to look at these things prior to placing an implant. Is the patient on a blood thinner? If so, is it okay to take them off or ask your physician that's associated with that patient? Is it okay to remove them from the blood thinners for a period of time? Remember that aspirin, even though it's very innocuous and you think, oh, I can buy aspirin over the counter, it basically can actually cause a problem with the platelets so they don't clot properly for a period of 7 to 10 days. Now, if the patient is taking an 81 milligram aspirin, not to worry. But if they don't know the difference and they're taking a 325 milligram aspirin, that patient is a patient that you should not do an implant on until they've been off of the aspirin, or at least the 325 milligram aspirin, for at least 7 to 10 days. What about smokers? Many of my patients in my private practice, I was in private practice for about 8 years. And after serving in the military, I went into private practice and I did that until I started to have problems with the shoulder. And my shoulder became an issue. So I went into teaching. So I teach both at Austin Community College in the dental hygiene program there. And then I also teach at the 1 year AEGD at the VA in Temple. Smokers. Mm. So I placed implants in smokers. And I would tell them right off the bat, as I do for any type of periodontal procedure, we will do the procedure, but the success of the procedure will be not nearly that of a non-smoker. In fact, one of the things that we do at the VA is that if the patient is a smoker, he or she is not entitled to implants. They have to quit, and they have to quit for 6 months or so with a negative cotinine test before we'll consider them for implant placement. What about periodontal patients? If the periodontium is under control, there's no worry. That means minimal probing depths, minimal bleeding, great. Or say the patient has lost all of their teeth because of periodontal disease, not so much of an issue. We can proceed. In fact, there are studies that look at what if the patients had really bad periodontal disease, and you've taken all their teeth out, are they more prone to implant failures? The answer is no, they're not. But we've removed all their teeth. So the bacteria that normally will cause periodontal disease will not necessarily be there anymore. And that's a good thing. What about patients that have had previous chemotherapy? That can be a real serious thing, especially if they've had some of the drugs like bisphosphonates. Bisphosphonates are one of my drugs of interest because I'm actually working on some different therapies for patients that have had bisphosphonates, which what the bisphosphonate does, if it's a patient that has cancer, the bisphosphonate works to decrease angiogenesis or the formation of blood vessels. It also prevents the tumor, in the case of cancer, from metastasizing. By the same token, many patients that have osteoporosis will take an oral form of the bisphosphonates in an attempt to slow down the osteoporosis that's occurring. Both drugs, although the oral not as severe, can cause a decrease in the blood vessels that are available to provide the healing effect when placing implants. So that can be a real issue. Now, you may say, well, take the patient off the medication for a while. But unfortunately, the half-life of bisphosphonates are 12 years. So even if you put the patient on what some people would say a drug holiday, in other words, hold the drug for a period of 6 months to a year, you still have to worry about the half-life of that drug, which again was 12 years. You also, just so you can safely administer vasoconstrictor with your local anesthesia, you want to make sure that the patient is cardiovascularly stable. They haven't had a heart attack within the last 6 months. They don't have a stroke within the last 6 months. Those are things, and their blood pressure is pretty well controlled. What about pain control afterwards? Well, luckily, with the procedures that I will show you and discuss today, pain control is minimal. We don't have to do too much. I rarely prescribe any sort of narcotics for patients that are having implants placed. Now, many years ago, say 10, 15 years ago, I would prescribe narcotics with NSAIDs, non-steroidal anti-inflammatory drugs, until I learned better. Now I know that you can control pain, the most severe pain, the best with nonsteroidal anti-inflammatory drugs like ibuprofen, coupled with Tylenol or acetaminophen to get very strong pain control. Antibiotics. Oh boy, here we go. Sometimes, we'd say, oh yeah, we always prescribe antibiotics for the patient after a gum surgery or an implant surgery. Well, I'll show you the literature. The literature says, this was back a long time ago, but it showed that even if you didn't prescribe antibiotics, i.e. this one was penicillin they were using, they showed there was no difference in the success, whether or between early or late postoperative infection or implant survival. Interesting, huh? Well, we at the VA have many people that have multiple comorbidities or health problems. And so we normally will prescribe them amoxicillin unless they tell us we're allergic to amoxicillin. Interesting, though, when you look at this study that was just done in 22, you can see that if that patient is allergic to amoxicillin, the implant failure rate is pretty low. And I'd say that's actually a higher rate than I normally see with our residents or with myself particularly. The failure rate is 8.4%. Now, the old drug we would always prescribe for patients that were allergic to amoxicillin is clindamycin. Clindamycin is no longer prescribed as an infective endocarditis prophylaxis in the United States, and it's rarely prescribed for those patients that want to prevent a late joint prosthetic infection. Because why? Because it just doesn't work very well. Look at the difference in the failure rate for patients that were placed on clindamycin. You went from an 8.4% failure rate to a 20% failure rate. So how about azithromycin? That's one of the ones that we actually say is still around for those prophylaxis I mentioned earlier. But look at the failure rate for that, 30%. If you didn't have any type of antibiotic prescribed, then the implant failure rate was very near the one that when we prescribed amoxicillin at 12%. So in other words, if you prescribe azithromycin and thinking there are patients allergic to amoxicillin, you're actually doubling the chance of that implant failing. That was a pretty interesting article and enlightening to me. What are some of the things we think about before we're getting ready to place the implant? Well, one is we need to make sure that we have looked at where that implant's going to be placed and is it going to be appropriate for the restoration of it and for it to be a chewing force within the dentition. If they have enough osseous support, great, let's go. If not, there are ways that we can augment that osseous tissue, osseous support, and I will show you some of those. What about the soft tissue? If it has great, adequate attached gingiva in the area where you're going to place the implant, then proceed. If not, when and how should we augment? And I'll mention that too. And then, of course, everybody wants to come in and have their tooth taken out and an implant placed and then to leave with that same tooth, don't they? Sometimes we can do that. Sometimes we can't. And I'll share some of those things. I mentioned earlier that if you don't keep the temperature of the bone cool, then you have an increased risk of what we call osteonecrosis of the bone. So I have and still do, whenever I work in an area I can do it, we chill our coolant when we're placing implants to cool the whole site and to cool the drill while we're drilling our osteotomy. And it's important because it also helps with the success of the implant long term. What about, like I mentioned before, the periodontal condition has to be stable. There has to be minimal bleeding on probing. They have to have stable probing depths. In other words, depths that have not changed with the attachment levels in a year or so. They can't have any pus or suppuration. It must be stable if you're going to place implants. It's just like building a house. When you build a house, you don't build it on sinking sand. You build it on a firm foundation. And that's what we need to have for placing implants because the same bacteria that cause periodontitis cause implants to fail. Those like Agribacter actinomycetum comitans, Porphyromonas gingivalis, Prevotella intermedia, Tannerella forsynthesis, Treponema denticola. So all those bacteria, if they're still present with active periodontal disease, they can affect that implant that's trying to integrate, and it cause for increased risk of failures. Surgical stents. These are great if they're done well. I'll show you some good ones and I'll show you some bad ones. They aid in the surgical placement of the actual implant fixture. And it really is important that you think about where the proper tooth position is going to be. And then how can we place that implant to make it the most acceptable and aesthetic implant restoration. It's nice if it retracts the soft tissue while you're placing it. But the downside is it can be kind of time consuming. I'll show you a couple of them. Here's one that was placed or was made. And you can see this type of actual stent, not so successful. Even the first drill is not able to penetrate or touch the bone. So what do we do in this case? Well, I would say argue that if it's a single tooth like that, and you've got teeth on each side of it, you can probably just freehand that just as well. And sure enough, that's what the operator did to get a nice placement of the implant. Now, when I'm teaching my residents, I almost always, when they're beginning, we get a nice guide or surgical guide, and that's what we use to help them find at least the first drill so that they know the inclination of the implant that's going to be placed, the apical coronal dimension, that buccal lingual, and the mesial distal dimension. And I'll show you a great stent that one of my prosthodontist friends, Van Ramos, placed. Van is now the head of prosthetics at University of Washington, and he was great to work with. He is an excellent prosthodontist. He does his own porcelain. It just looks fabulous. And I'll show you a couple of his cases. Here's a stent that he made. He said, well, here, Dr. Reeves, I want you to place, and you can see, I'm going to see if I can do my annotation here, get my fancy annotator tool here. And then you can see that, where's my little guy? There he is. I want to do this one and this one. You can see that he said, I want it to be right here so that you actually have about 3 millimeters from the base of this stent is where I want you to have the platform of that implant. I said, oh, that's nice. Because not only did it give me apical coronal dimensions or where he'd like to have that placed, it gave me buccal lingual and it gave me mesial distal as well. And you can see that the time I was placing, we were placing a 3i implant, which is, I think, also called Biomet now, I believe. Nice implant. Sorry. There we go. And you can see that after we place the implant, that's what we have, okay? It works pretty nicely there, okay? Let's see if I can get rid of that for us because that was a little bit of an issue if it's going to stay there. There we go. All right, now we're back. So you can see that when we looked at this, the actual surgical guide, we did pretty spot on. And when we restored this case, which I'll show you a little bit later, it turned out very nicely. And that's what we want to see. Something that's helpful and something that's usable. But sometimes we don't have enough hard tissue. Sometimes we have to bump up the sinus, whether it be from a lateral window procedure, whether it be from a bone-added osteotome sinus floor elevation, or perhaps we don't have enough buccal palatal or buccal lingual width. We might do some guided bone regeneration. And one way that we can prepare a site and always prepare it well is with ridge preservation. I'll show you some of those. As far as soft tissue grafting, if you don't have good tissue around there, I'm going to show you some of the sequelae that come from that or some of the things that can happen. And we can use a patient's own tissue, which is probably the preferential way, is their connective tissue graft or a free tissue autograft or a free gingival graft, some people call it, or perhaps even with a product called Alloderm. This is taken from a journal, but you can see the premise behind it. And I do have some, I've done many of these myself. But you have to make sure that you have an adequate amount of bone that's from here to here to be able to place the implants at the time that you actually do the sinus floor elevation. So in the maxilla, you can see we made a small window. We elevated the Schneiderian membrane, placed the implant, and then they came back and actually added the bone graft afterwards. And that works well. I'm telling you, I'm going to show you in a second the actual literature and what it says. The literature shows, this is Paul Rosen that showed that, if they were smokers, they still had a success rate of 93% in this bone-added osteotome sinus floor elevation. And even the same is going to be in what we did with the lateral window procedure. If the patients had less than 4 millimeters of bone, crestal bone, that's when we say, not going to place the implant. And again, so I always go for, and Paul Rosen would say at least 6 millimeters of that good crestal bone to get that initial stabilization. Let's show you a little procedure here. Oops, I'm sorry, go back one. This is going to go through our procedure of how we do this actual lift with an osteotome. Maybe. It worked a minute ago. There it goes. So you can see with an osteotome, a little different procedure. We don't make a hole in the side of the sinus or the maxilla. We actually go in from the crestal portion and we use increasingly larger osteotomes to impact the sinus floor and take that floor of the sinus up, lift it, as well as the Schneiderian membrane that lines that sinus. Now, again, if you have an adequate amount of crestal bone to the floor of the sinus, it's great. You can go ahead and place the implant at the time that you did your sinus lift. If you do not have the 6 millimeters, then we may want to prepare the site first, let it heal from anywhere to 6 to 9 months, and then come back and do your implants at a later date. Now, note, if the patient moves away and comes back 4 years later, that bone may not be there because there was nothing there to keep it in place and to stimulate the bone formation. So here you can see now implants in place, and you can see that now we have a good result for that patient. Here are a few cases that I actually did myself, where just not quite enough bone to place the implant here in the desired length. So I did a little bit of a sinus bump procedure, and you can see that there. This is as it's healed. You can see the nice result. And as that bone gets more and more mature, you can see that now it resembles the same bone as you see in the surrounding area when it has the healing abutment on it. That's a great case. Great little chance to do that. A nice little lift. Here's another one. Uh-oh. We'd like to go straight in the middle of those two teeth, wouldn't we, with our sinus lift? But unfortunately, you can see right here that you can see the septum that's in that sinus that's going to give us a little trouble. If we had gone straight into that, we would have splintered that septum and we could have torn the Schneiderian membrane to the point where we wouldn't get good approximation and osseous growth in that area. But you can see that I skirted it by going a little bit mesial to the septum and did my sinus bump and placed the implant. Very nice procedure, works well. Now, I mentioned earlier that sometimes we have to increase the buccal lingual width of a ridge. And you can see when we look at this, that it's kind of collapsed. When they had the tooth taken out, there was no ridge preservation done. And as a result, the ridge collapsed quite a bit in that buccal lingual dimension. So in this case, I reflected a flap. I perforated the cortex with several little pinpoint perforations. I added a bone graft underneath that, and then a titanium reinforced membrane with a couple of tacks to augment this area so that when we get after it heals, again, 6 to 9 months, we would have nice bone in there to actually use for our implant. You may be asking, well, can you grow it in the apical coronal dimension too, doctor? I would say if you tried to put a tent pin here and you had a nice fitting and nice membrane that has good stabilization and has good stay in it, like this titanium reinforcement, it's possible to get some. I'll show you another technique in a minute, how we actually obtain some of that. So this case, originally, I tried to place an implant in the maxilla and not enough facial bone to support an implant and also to make it look aesthetic. So I did exactly what I was mentioning before. Here is the membrane after it's been healed for 6 to 9 months. I then go in and take out those pins, peel back the membrane, and this is what I see. Look at that tissue. That is good, hard bone. Then I can go back and I can place my implant and still have plenty of facial bone so that I get a nice aesthetic result of that case. Pretty cool. Here's one that we did also. You can see this is what I would call an Allen B or Allen C defect, where we've got some a little bit of buccolingual concavities, but we also have a little bit of the apical coronal dimension as well. We did a similar thing, and it worked out very nicely for the patient. What about ridge preservation? When you're taking a tooth out, particularly in the anterior region, expect that tooth or that socket to resorb quite a bit, unless you do something to preserve that ridge. Now, even with ridge preservation, you may get a little bit of loss of bone in the buccal-palatal dimension, but it's much less than if you did nothing. I will tell you that in the posterior, though, if you have a nice thick biotype or thick bone on each side of the actual extraction socket, that perhaps the extraction was pretty straightforward and you didn't have to do much in the way of drilling to get the tooth out. You maybe used a nice desmotome and were able to tease those roots out after splitting the tooth. You maybe could get away without doing ridge preservation. But whenever you have to drill away bone to get a tooth out, you should think about preserving the ridge. Now, there's different thoughts and different ways. I love the Cytoplast Tech TXT 200. It's a non-resorbable. It's a EPTFE, polytetrafluoroethylene membrane expanded, and it goes and you fit that over the actual site. At 3 weeks or so, you tease that out. With this technique and ridge preservation, I actually have had bone deposition above the crest of bone using this technique. Because I'm actually one of my assistants when I had to take a tooth out for her, and we placed the implant later. But you can do the delayed implant technique where, you go in, you take the tooth out, you do your bone graft, you let that sit 3 to 4 months, and then you can go in and place your implant. At least then you've got something to partially secure your implant and make sure that it's stable upon placement. Now, there's different types of things you can fill in that defect with, either freeze-dried bone allograft or demineralized freeze-dried bone allograft, or you can use bio-os, depending upon where you're practicing. Some people would just do a membrane alone. I've seen that work. People will use BioGuide, which is a resorbable membrane in bone. Not as successful, but it does work. But I love the cytoplast. I'll show you a case. Here we go. So you can see by radiograph that this was a very heavily resorbed tooth. And upon extraction, you can see what it looked like. Look at the extensive resorption that occurred. Looks like maybe my resident had tried to fix it, but then discovered by taking a radiograph that it needed to be extracted. So here's the site. So what we did was we put bone, freeze-dried bone allograft, or demineralized freeze-dried bone allograft, I'm not sure which, but we put that non-resorbable membrane over the actual graft socket. And we tied it so it wouldn't move out with some non-resorbable cytoplast membranes or sutures. Now, I have no royalties to proclaim. I don't have stock in anything. I just have stock in what works for me and has for the last 30 years. So this works really nicely. You can leave these sutures in for 3, 4 weeks if you want. Interestingly, this material is used oftentimes to patch if a patient has an aneurysm in their, say, abdominal aortic aneurysm or something like that. They use this material to patch it and reinforce it. And same thing with hernia surgery. These type of things they use meshes that are very similar. So the body tolerates it, and you can leave it in for long periods of time that way. So went ahead and used a kind of a flipper or a transitional partial denture in this case, sutured it all closed, and then came back about 4 months later, placed the implant. But you can see even with the bone preservation, there's a little bit loss of bone there. So we grafted it again and we placed it and we went ahead and actually, it turned out to be a very aesthetic case. Almost always, if I'm doing an implant in the aesthetic zone, I will probably use some sort of a bone graft if I've had to reflect this flap at all. Here's another case where this tooth, also another tooth that was resorbed, we took it out, and at the time of extraction of the tooth, which obviously I was very careful, you can see that I split that facial plate. Now we had hopes of placing 2 implants here, but to borrow a term from some of the people that are periodontists, the facial plate determines the fate. In other words, because that facial plate was not intact, this was not a candidate to do an immediate implant on this case. So essentially what we did, here's the extracted tooth that had resorption on it. We grafted it really well and closed it. In this case, I would probably wait, 4 months or so, maybe 5, come back and retry to place the implants in those areas. And that's what we did. What if you don't have good tissue around here? Now, interesting, I've seen that oral surgeons in the past, I don't know if they still do it, but they will take a skin graft from the patient's hip or someplace else on their body and use that. Well, when you do that, you see these type of eruptive type lesions that occur because it's not actual oral tissue, is it? Also, you see over here, when you look at this implant over here, you can see that there's inflammation and redness, basically because it doesn't have good tissue around it. So in this case, you can go to the actual palate and you can harvest a nice sized palatal uh, soft tissue graft and place it down there and tack it down. And when it heals, you can see now, look at this amount of attached gingiva. around those implants from which now you can restore those areas. That works really nicely, doesn't it now? We get a quick swig of water. There's two ways you can place the implants. One is sometimes if the torque value when we insert those implants is very high, in other words, it's very stable, we can put the healing abutment on the same time. Now, I will also show you a case where I actually did the immediate placement of an implant after an extraction. We placed the permanent abutment on it, and we placed a provisional tooth on it. And it turned out beautiful, and I'll show you that in a bit. Two-stage means I don't think I have as good a stabilization that I would like to have with that implant. So we're going to leave it submerged. We'll put a cover screw on it, or healing cap, some people call it. Cover that back up. And at the 3-month or 4-month time frame, we'll come back, we'll open that area up, and then we can place the healing abutment. Or if it's in a posterior area, I will tell my residents, you can go ahead and take an impression at that point. If it's in an anterior region, I probably would not tell them to do that. I would say, let's wait, give it another month, let those tissues kind of settle into where they're going to be, and that will work nicely. Now, there are systems that will use a actual custom abutment, which work really nice at forming that tissue emergence profile. And we encourage that whenever whenever dentists want to try that. So at the time of the second stage surgery, you put a custom healing abutment on it, and you can actually make that custom healing abutment so that it will form the emergence profile for whatever size tooth you're actually placing there. What about putting a tooth on it that day? Well, that works sometimes. Sometimes it doesn't. It depends upon the density of the bone. And even now, my new group of residents, I've been teaching residents at the VA now for 10 years. Even now, after maybe 7 months or 8 months of residency, they can tell when the bone is dense enough that they feel that we can put either a healing abutment on at that time, or even possibly doing a non-occlusal loaded immediate temporary restoration. But you have to have really good insertion torque. And to do it as an immediate, you have to make sure that there's no apical pathology. So this would be maybe a tooth that had fractured where you can't see any type of enamel at the CEJ on radiograph. And you know that the tooth overall is a pretty healthy tooth. You take it out atraumatically using desmotomes or piezotomes or combination of. You place a very nice implant. You place it at least 3 millimeters apical to the existing extraction socket. And when you place this implant, you direct it so that it goes more palatally than the existing extraction socket. Now, the controlled loads is important if you're going to put a tooth on an immediate placed implant because you want to decrease all loads on that area, or the micro movement that can occur through occlusion can cause the implant not to integrate and to be unsuccessful. Now, this mostly, I would say, only with sort of those osteoconductive implant surfaces, those that have treated surfaces. I don't care which brand you use, they're all pretty similar, but the surface needs to be treated for it to be more successful. Now, we'll show you a new caveat that I just learned recently, and that's cool. So immediate non-occlusal loading, when can we do that? When we have enough room, enough bone to place an implant beyond where the existing root was, when we know that the patient will heal pretty normally, when we know that the patient understands the benefits. I would say in my private practice, I would tell the patient, now we can put a temporary tooth on it, but it's going to cost you more money. And if you bite on it at any time during that couple 3 months of it integrating, it could cause that implant not to integrate. And some people would say, "Nah, I'll forget. I'm not going to have it done. I'm going to forget. I'll forget to do that." So they're not willing to take that risk. And as long as they understand the risk and are willing to do it, that's fine. And then go over with them afterwards what's so important, i.e., tooth's in there for pretty looks. It's for what I call a party tooth, but it's not in there for function yet. In fact, when we place them out of occlusion, and you really don't want much in the way of interproximal contact with those type of restorations. Here's an example. So in this case, the tooth you see on the right, which is the patient's number 9, um, and depending on where you're at, what your nomenclature is, we didn't have enough ferrule effect or enough tooth to grab onto. So my prosthodontist friend, Dr. Ramos, said, let's take that one out and let's go ahead and place an immediate, um, go ahead and place that implant immediately. And I think if we can get enough bone apical to where the existing tooth is, I said, I think we can go ahead and put a temporary out that day. Another thing that he did, which was really cool, and I wish we had this at the VA, is he made an index at the time of the placement of the index of the placement of the implant, so that he could transfer it to a cast, so that he could actually fabricate the abutment and the crown at the time at the which we thought the implant was integrated after 3 months or 4 months. Pretty cool. Even for a single tooth implant, we were able to do this and do it predictably. So the next picture, you can see this. Here's what the patient first came in with. Here's what he left with at a few weeks. You can see that the temporaries look nice. The healing is very nice and it works really predictably. But you have to follow all those things that we just talked about. If you're just starting in placement of implants, I would probably recommend that you start in the posterior, the back part of the mouth, and work with those first till you feel pretty comfortable with it. Because when you're doing things of this nature, I would also recommend that you work with a prosthodontist that can help you do that, everything together. Or if you're a very accomplished general dentist, that's okay too. Here's another case we did. We said, oh, we can do this one. He's got plenty of bone. So we placed the implant. And this was no tooth taken out, luckily. But we placed the implant. Here's his beautiful stent again. You can see that nice stent that gave me both the mesial distal, the buccal lingual, and the apical coronal dimensions. And you can see my perioprobe going through here. So it's 3 millimeters from where he wants that gingival margin to end up, didn't it? That's what we like to see. But you can also see when the implant's placed here, a little bit of a dull haze, which tells us we're pretty close to that. And we don't want to have a dehiscence form or a fenestration down the road. So we went ahead and placed some bone graft, as you see here. Here's the implant placed. We placed some bone graft in a membrane. Here's the bone in place, the membrane over the top of it, sutured it closed. He went ahead and made the temporary abutment on the tooth that day, and he went ahead and put the tooth on it. So we waited 3 months, and this is what it looked like. Wow, look at the tissues. The tissues are happy. In fact, we may, when we take this and convert it to the final restoration, we may have to take a little tissue away, mightn't we? Because it's had such a great response by the tissues that, in fact, we have a little bit extra. We'd like to see it at approximately the same line as the adjacent incisor, not so much as what we see at the canine or canine. When we're thinking about doing incisions, there's different flap designs. And I'm going to go over some of those so you have an indication of what I use and what I teach. If it's in a dentulous area, you can do whatever you want. Some people might do a flapless. Some people might do basically do my small incisions like you see here. If you're doing a flapless one, I've seen people just take a little, like a small biopsy punch and punch out this tissue where you know the implant is. I would only do that though if I've had a CAT scan of the area and I know exactly where the bone is and how much is there. In this case, just looking at it, it looks pretty good, doesn't it? But also you have to think about things like those tori that are there. No wonder the patient struggled with a lower denture, because you can see that if he has this undercut in here, the denture would never really work for them, or at least it wouldn't work well. So you should have had these removed perhaps. So when I make my incisions, I make it with even some lingual and vertical releases, as long as I'm mesial to where I think the lingual nerve has dipped into the tongue area. And that's generally about the first premolar area or second premolar mesial of the second premolar. So right in that area, you can make a vertical incision to avoid tearing the tissues. The worst thing that can happen is when you're doing a flap, reflecting a flap, you tear those tissues. then you're not getting a clean cut and the healing's going to be not so great. Okay. So in this case, maybe you want to go all the way across the ridge and do your vertical releasing incisions on each side to expose this whole ridge so you can find the best location to place your implant. In this case, when you're doing just a one implant, single tooth implant, and you're going to do maybe one molar here or maybe, something like that, this would be the design I would tell my residents. Come, do a vertical release on the lingual, past the mucogingival junction, go crestal, and then on facial, do facial releasing incisions and envelope around the lingual of this tooth. Because we know that we can't do any sort of a lingual vertical release in this area, or we may cause paresthesia or anesthesia to that tongue area. So we don't want to do it there. Now here it's okay, because the lingual nerve is already, if you remember your anatomy, the lingual nerve has already dipped right about here and gone into the tongue region to innervate the tongue. Here's some other examples of flap designs, very similar. Maxillary arch. You can see here it is. I do like a basically a kind of a square type incision. You want to stay away from here where you see that where the greater palatine foramen would be, so you kind of avoid that. And these excisions may be a little bit exaggerated on the length of them they need to be, but you need to see the ridge. So to see the ridge, you need to make sure that you expose the ridge. And then you need to have the patient close down into occlusion and make sure that where you're figuring on providing the implants, that in fact, that works pretty predictably to restore the teeth dentition. Now, if we're doing an anterior area, you can see I did something a little bit different. On these other areas, I reflected the whole papilla area, didn't I? And the anterior, what I would do is I would do what I call papilla saving, preserving procedure, where I leave the tissue right next to the tooth alone. That's so that when I place the implant, I don't have any problems with forming a nice papilla because we know we've already got one there, don't we? Again, know your anatomy so that you don't do any damage to the patient. Types or brands. The original one, like I said, was a Noble Biocare by Brandemark. It was an external connection, and that was back around 1981 or so. It had a machine surface. It was just a smooth surface. Today, we don't have much of that. We mostly have the roughened surface, at least on the apical portion of it. There's various designs, there's various types of connection, but the ones that we look at most commonly now are either the internal connection of some sort, whether it be a trilobe or a conical connection. And all of them, fortunately, have very similar success rates. This is the newest and best from Nobel. I noticed this just yesterday or the other day when I was looking at it. And I liked it because it has good treatment of the implant surface that's going to be integrated. But then at the top, they made it some kind of a material that's machined and not roughened. This was my concern probably a couple decades ago when they came out with the fully treated surface of the implant. What about if the patient has plaque develop around that implant? What's that going to happen? Well, I'm going to tell you what's going to happen. That treated surface can act like calculus on a root. And a calculus on a root harbors bacteria, and then we have bone loss, and because of the whole host response to that bacteria. So I like this new design. And no, or I mean, 3i Biomet has always had this where you have the non-treated surface at the very coronal aspect. It allows for good soft tissue attachment, and unless that you get loss of bone all the way down to this first thread, you avoid that problem with the actual calculus analogy. Here's another one, the Tyenite Nobel replace. It's got the trilobe. It used to be Stereos a long time ago. There's lots of different ones that are similar to these. I use these a lot and I liked them. They were really good implants. And right now we don't use that one, but we are at the VA using something different, and I'll share that with you. One that I really like, and this is the one, the Noble Active, and I see that they've changed the coronal aspect of that as well. And I like it because it's really good in compromised bone situations. It's a cutting surface. So when I'm using it for an immediate implant, I can actually go in halfway through and redirect my angulation of my implant drilling to get the premier and absolute best contact with that palatal bone. So that's what I really love about it. It's also platform shifted. Most people do that today. I don't know if you know the story, but that was actually done one time by accident. And when they noticed that basically you had less bone loss around that junction between the abutment and the implant itself, they said, wow, why is that? Why is that? Well, the actual reason is that you've shifted. If you put a tooth on here that's a little bit narrower than the actual inside of the implant, then your biologic dimension now goes sideways a millimeter and down a millimeter instead of down 2 millimeters. That's the beauty of the shifted platforms. That's pretty cool, isn't it? Again, Nobel has lots of different ones with lots of different custom abutments, and there's zirconia abutments you can use, and there's titanium abutments, and this new product I can't think they call it Neil or Heel or something like that. And there's always got to be changes so that you have to buy new stuff, isn't it? This is the one we use at the VA. I've never been thrilled with it, but it works pretty well. And it has a treated surface all the way to the top. I don't like that so much, but it's easy to insert, it's easy to restore, and has good literature success. So we use it. What about this situation you see here, where you got 4 implants to place? Patient wants more implants. Well, implants are great for patients that have no teeth. And I'll always tell my patients, implants are replacements for no teeth, but they're never replacements for your teeth. So as a periodontist, my duty is to try to preserve the dentition in health, function, and comfort. Once those teeth are lost, then we consider things like implants, right? Once a patient loses their teeth, some people will do fine with dentures. My dad wore his for 30 some years and never had them remade. Shame on him. I couldn't do it at that time. I was in active duty military. I would have done it for him. But dentures don't preserve the bone, do they? And the mandibular denture can be very hard for some people to adapt to. So, what are our solutions? Well, implants. Implants are a great solution. Let's look at the functional capacity of patients that have no teeth. If you have all your teeth, you've got 100% capacity function. If you have no teeth and no denture, you have 0% functional capacity. If you have a denture, a lower denture, wow, now you're all the way up to 10%. If you put a couple implants in and now you support that denture, you've increased the functional capacity for that lower arch up to 60%. If you do a basically an implant born bridge, then you're almost to the same level of functional capacity as you did with the patient's natural teeth. That's why lots of people like what we call the all-on-4. And the all-on-4 means you put 4 implants in. This patient they took out all their dentition. As a periodontist, I look at that and I go, well, maybe we could have saved a few of those teeth. But, as an oral surgeon, they'd say, yeah, let's take them all out. Anyways, so they reflected everything back after they had taken the teeth out. And then they actually, through CT guiding, they can actually figure out where the sinus is, or they can do it via a small little hole in the maxillary sinus to actually feel for the anterior wall of that sinus. And then they angle the implants such that they place them so that it avoids having to go do any type of a sinus lift. That's a great thought. Here it is after they've been placed. The chimneys they stick up through there. Then sometimes they can cover it with a rubber dam and they line a denture so that once the patient leaves, they leave with a secure set of teeth in their mouth. Hey, people here in Austin go to a place called Clear Choice that they pay, anywhere $40,000 per arch to have this done because they're so needy or so in need of having teeth that are going to be functional the same day. Now, you may say to yourself, well, how does that even work? How can you do that? We just said that with a single tooth, when you place it immediately, that you have to be careful with any occlusion on it and everything else. Well, the difference is you've got stabilization cross arch. You've got stabilization in this posterior, anterior, posterior dimension. So you have cross arch stabilization and you've got a multiple tripod effect. So you can see here's a tripod, see here's a tripod. That's what makes it stable. That's what makes it worse. And when you look at the final radiograph after it's placed, they did a nice job, didn't they? Okay, they've placed two in the anterior. They've done those couple skirting the sinus. They did a couple in the mandibular arch. This patient's going to be a very happy patient. How do we do that? Well, we can do it through guided. We can send them through a CT scan, or now we have cone beam CTs, which will give us this ability to actually treatment plan it in different types of software. This would be the Procera software that I used when I was in private practice. Today, this is really interesting. I have not played with it yet. Maybe I will, maybe I won't this point in my career. But they have real-time guidance using different types of mechanisms to while you're placing the implant, you can see real-time 3D guidance. Wow, is that cool or what? That is really awesome. Most of the ones we do or have done in the past is all on fours with Nobel Guide. You can see they once you set it up in the CT scanner, you send it off to the lab. They make you this nice guide stent. And what you see here is these little spots on the side. You actually put pins in the maxilla to stabilize that. And then you use drills that are progressively larger in size that fit inside this sleeve to make a nice CT guided implant system for the all-on-four. It works. It's great. And the patients love it. We don't do much of this at the VA. In fact, we don't do any of it at the VA because everybody would want it, but it works well in private practice. Now, when we're placing implants, we have to think about two different types of implant restorations, don't we? We have to know that there's one that's cemented. So you have the abutment that fits down over the implant, and you can either make it at the same time that you do the crown or not. And that's when if the implant isn't placed perfectly the way you want it, you may think, I have to use a cemented crown to get a nice aesthetic effect. In the posterior, I would try to place the implants in an area where you can do what you see here, and that's the screw retained crown, where the crown and the abutment are all in one piece. And if you do that, then if there's ever a problem, you can take this implant off. You can treat the implant or take the crown off, take the crown off, treat the implant, and put the crown back on after it's healed. And we've done that a few times. So that's the advantage of that. Now, in the anterior, it makes it a little bit tougher. Now, they do make some products with screws that have an angle on them, et cetera. But most of the time at the VA, we're going to tell the students or the residents to make sure and just go ahead and plan on doing a cemented crown, because unless we just have perfect placement of the implant, we're not going to be able to use that screw retained crown very often. What about two implants close to each other? This is something you have to think about. And this is something that Dennis Tarnow talked about way back in 2000, is that when you put two implants close to each other like that, you have to consider that there has to be a distance between them that's appropriate, because remember, we don't have that connective tissue attachment into the implant, do we? That connective tissue attachment, when it's into the implant, will hold the bone up. So you have to make this a significant distance, at least 3 to 4 millimeters apart, to retain this papilla that you see there. So when you're planning your implants, you have to think, well, if I have to do 3 to 4 millimeters, I'm going to be 2 to 3 millimeters from a tooth, 2 to 3 millimeters from a tooth. I'm going to have 3 to 4 millimeters in between. How many millimeters do I have to have? Well, that's like 17 probably, or 18 for a two-tooth implant placement between in an edentulous area, right? So always think about that. The other thing you have to think about is this. If you put them too close together, you're going to lose the bone. And remember that the bone always follows the papilla, the soft tissue, always follows the bone. So if you put them too close together, you're going to lose the papilla, you're going to lose the bone, and you're going to have a mess. I'm going to show you a case of that in a little bit. So too much? What about too much? Well, it's not as bad. You may not have as big a papilla as you had, but you still got the bone. The main thing is it has to be greater than 3 millimeters or 4 millimeters. Otherwise, you're going to lose this bone like you see here. Okay, important concept. Well, how close to the tooth can we be? We can be close to the tooth. Here's a natural tooth. Here's an implant. When you look at this, though, what holds this bone up? Well, it's these connective tissue attachments on the natural tooth into the bone that will retain that bone. That's the beauty of it. So when you place one implant next to a natural tooth, you can anticipate that you're going to have a nice result. Because in the anterior zone, you always want to have a nice aesthetic result. You want function, but at least in the United States and Austin, Texas, people want to look nice too. Here's that case that we started earlier, didn't we? Okay. Now we knew that there was not enough room for us to place 4 implants in this area because we calculated it out. Even with a 3.0 width implant, we didn't have enough room. So my friend Dr. Ramos said, well, when you have a tooth and you've got, a teeth that you can't place 4 implants, we can place 2 implants and we can cantilever the laterals off those central incisor implants. And that's exactly how he did. Look at this. He did all his own porcelain. He did his pink porcelain. And now we've got a cantilever so the patient can get underneath there and they can floss underneath there. They can get their water pick, which is I'm a big advocate of the water flossers, the water picks. They can get in there with some little soft picks or whatever in between the 2 implants, and yet they have an aesthetic result. So the kid came in, this was a soldier, he came in with this flipper, it was okay. He didn't smile much, and he ended up looking like this, okay? So he wouldn't smile with that flipper in. But when he left, look at the size smile he had. He was so excited. Now he can actually smile when he goes out in public. That's a success. That's what you want to develop, okay? What about implants that don't work? When you start to see this, you see a fibrous encapsulation of that implant, it's failed. It needs to be taken out. So with that, what causes periimplantitis can be the bacteria. Remember, we talked about the perio having to be under control. It can be the biomechanical or occlusal overload because remember that when you place an implant and it's next to natural teeth, you need to take the final restoration out of occlusion a little bit. If not, when the patient occludes and presses down on the PDLs, periodontal ligaments on each side of the teeth, that implant, which is ankylosed, will not move. So it's going to take all the brunt of that occlusion. And when I was in private practice, what I normally would do, and I learned this the hard way, a lot of my things I've learned along my 30 years of doing implants is that there are certain things I'm going to check to make sure no one else messes them up. I would have the patient back a month after they had the restoration placed to make sure that the restoration was out of occlusion slightly. Now that means pull shim stock. I like to use that thick blue occlusal paper. Anything I can pull out from where the implant is, I know that implant's not going to get overloaded. One time when I first started in private practice, I didn't do that. I trusted that the dentist would know that. And guess what? I had implants that failed because of the fact that they were in biomechanical overload or occlusal overload. Also, we have to know about periimplantitis, we talked about the quality and the quantity of the bone. You got to make sure you have plenty. What do we do if an implant does start to fail and you have to take it out? Well, if we have an implant that's starting to fail, we can go in if we get one that's what we call ailing or ailing failing, we can go in and we can reflect the tissues back from that area. If there are threads exposed and we cannot graft those threads, because again, I can't grow bone up a stick. Only in certain individual cases do I have that option. And that one I've shared earlier was when we had an extraction socket, which we had a four-wall bony defect, basically an extraction socket, right? When you have a bone or an apple on a stick or a bone, you can't grow bone up a stick no matter what you try to do. So what we do when we have threads exposed, we detoxify those with an air abrasive. We use citric acid or tetracycline or doxycycline. And then we use chlorhexidine. And then we will also do this. We'll remove the threads. We'll polish that supracrustal implant surface. We'll usually do the implantoplasty first, and then we detoxify. I should have reorder that when I look at that next time. Here's an example my resident did not too long ago. The patient came in, maxillary placed implants, not well planned out, not using CT guidance, suppuration all in this area with bleeding. Well, you can see why. There was not enough bone to place the size of implants that they placed in these areas. They weren't mobile. We thought, we can probably save them. If we have any graftable defects, sometimes we'll do a bone graft, but if there's any implants that are exposed that won't be grafted, we're going to smooth them back with what we call implantoplasty. And we take a carbide burr, like a finishing burr, we polish them back, then we'll take a white stone and we'll polish them even more and then close the flap. Here you see it closed, and this was at 2 weeks. Hey, look at the tissue tone. There's no suppuration. Will it last forever? I don't know. Will it help the patient so they can maintain those implants for another 4 years, 5 years? Maybe. In dentistry, we think that everything has to last a lifetime. In medicine, if at 5 years you've been cancer free, that's called a cure, isn't it? Why is it that we are so hard on ourselves to think everything we do has to last a lifetime? It may not. But if it gives a patient 4 or 5 more years of good use of these implants, great. Again, sometimes we'll do bone grafting. We'll remove any granulation tissue. We'll establish a good bone graft, and we'll do all that. And then we let it heal 6 months and come back. Look at this one, though. There's no way you can do a bone graft around that. I can't grow bone in this dimension. No way. So this was poorly placed. So you have to know what your bone looks like, and you have to know how to handle it. When it becomes the point where you have to take it out, sometimes you can take it out with just a forceps. But then think about preparing for that site for another implant. What if back here, if this was a 4.0 size 4 millimeter implant placed back here, and we took this implant out and we cleaned out the defect real well, could maybe we put a 5 or a 6 millimeter width implant back there? Maybe, if there's enough bone, that's perhaps. Or we may want to augment and do ridge preservation in those areas, come back and do it later. When do we take an implant out? If you're placing implants, you have to know how to handle them if they have a problem, don't you? If the patient says this hurts all the time, if it's mobile, if it has chronic infections that are not able to be treated, sometimes I'll treat it with things like Arrestin. We'll try some antibiotics, etc. All those things are good for trying to, keep it in for a little bit longer. What if it has significant or progressive bone loss? What if it hurts all the time? What if it has bone loss greater than 75%, which you see like this? You cannot grow this back. This has to be taken out, do ridge preservation, maybe come back later and try it again. Here's another case. What about this? Look at this example. And look, they tried to fix their mistake by making the crown longer. That's not so great. If you think that with the implant that's there, it's causing damage to the adjacent tooth, I've had this happen with a resident once before, in that they basically what they did is they basically did placed the implant and it nicked an adjacent tooth. When they did that, we had to do root canal on the tooth as well. Sometimes patients will say, my implant came out. And you say, yeah, sure, it came out. Okay, whatever. But what you really know is that probably it's the healing abutment or the cover screw that came off of it. In this case, it was actually the implant itself. Here's a case where we had significant amount of implant or bone loss. We took this implant out. It was one of the hydroxyapatite coated implants originally, which when they fail, they make a pretty sizable defect, and you can see what's happening there. Went ahead, grafted it, membrane came back, and then after 2 or 3 months, we can go back and place another implant. Implants have problems. Your abutment screws can break, and you have to tease them out. Things like this. I had a zirconia abutment actually break off in the inside of a Nobel Active implant. So you don't think I was nervous trying to drill this out without bothering the internal aspect of those screws? But I got it out and we restored it with titanium, and hasn't been a problem since. At the VA, we see this a lot. These were asteroconical type implants, which we no longer use since I've been coming to the VA. But look at this. The patient fractured it in multiple dimensions. You got to just take these out. You can't do anything for those. Got to take them out, let it heal, and maybe try it again, but maybe adjust the occlusion so they're not hitting on those areas so much. What about aesthetic problems? Poor planning. Look at this. Implant there, an implant interproximal there. There wasn't enough bone, so you can see that now they have dehisced all this area here, and you can't do much with that other than what we showed you in the last few slides ago. Another case here. Periodontal disease not controlled is what you're going to see. Look at this one. Remember I said you can't put implants too close together. This was done by oral surgeons at Walter Reed in Washington, D.C. Look at the size of these implants they placed. Look how close they are together. What do you predict? You predict there'd be no bone there. And sure enough, no bone there. Okay. He was going to deploy soon, but Dr. Ramos said I can do something at least to make it look a little nicer. So he did pink porcelain in that area, and it looks pretty decent. But boy, it's a shame that it ever happened. Implants work, but they're not 100%. This was a screw retained crown and abutment on this implant. Had a sinus lift on it, but the screw came a little bit loose. The tooth got into occlusion. So what happened? Well, the implant didn't fail, but the grafting that was done in this site beforehand actually had a sequestrum of bone that tumbled out. This is actually me. I helped place the implant. I advised the periodontist when she was placed or coming in to repair this. I said, make a nice big flap. You know, we'll have to do periosteal release. You need a passive closure. We can bone graft around that and then so forth. And she flapped it back. She likes mini flaps. My adage is always mini flap, mini surgeon, big flap, big surgeon. Okay. You can tell that, but when she put this back and she didn't have good closure, she grafted it, but I have a big defect around my implant. I don't like that. Here's the size. Look at the size of the sequestrum that tumbled out of that. What about when you design the crown? It has to be designed so it's not a watermelon on a stick. I saw this one that came in the other day. I said, oh, I have to get an image of that. Because look at this, the actual crown that was put on this implant. The implant was not properly placed. It should have been placed more like this. But they said, we'll just put a big old hanking crown on that. And now what you see is there's bone loss that goes almost all the way down to that edge of that implant, as well as bone loss all the way down this implant. Possibly by changing the occlusal scheme on this, or maybe telling the patient you're going to have a gap between your two teeth back there, that implant would still be in the mouth. It's not. If it's ailing or it's failing or it failed is when we take it out. That's when it's mobile, isn't it? When you start to have issues, you can look at this. This is a cumulative interceptive support therapy because if you're placing implants, you have to be able to take care of them. You can look at this on your own if you need to. We can share this slide with you. I sent the handouts to Dr. Onarobi, and he'd be glad to forward those on to you if you'd like to see those as a PDF. What are some implant criteria for success? You don't want to see pain. You don't want to see infection. You don't want to see suppuration. You don't want to see violation of vital structures. You want to see that the implant's is immobile. You don't want to see radiolucencies. You don't want to see a lot of bone loss. And you want the patient and the dentist to be satisfied. Now, every dentist satisfaction level can vary, can't it? Let me show you this case, though. This was a case that I told you about. I did a little foreshadowing earlier in the lecture. I said, this patient came in with pink tooth. Pink tooth means that they've got resorption. You can see the amount of resorption that had occurred with this tooth here. So I said, you've got a lot of room. I've got lots of room. I can place an implant. We can do this as an immediate. I can do an immediate abutment, final abutment, which is a zirconia abutment that I put on it. And we can put a temporary crown on because I'm confident enough that because when I take this tooth out, I can get enough stabilization apical to that it's going to be stable. So that's what I did. Here's your implant. Look at the length of that implant. But it was stable enough. I could put the final abutment on it. And this was the final crown that was actually put on it. And you may say, look, he's lost a little soft tissue there. Well, not really. Look at what it was before. Actually, soft tissue has gained a little bit, hasn't it? It's a little bit better than what it was. Also remind patients, though, if they have implants, that doesn't mean they don't brush them. I literally have had patients say, well, I don't have to brush anymore. I've got implants. And I said, oh, you've got to do better than you did before. This is your new lease on life. So you have them use things like motorized or powered brushes, Sonicare, Oral-B. Make sure they use maybe a water pick because even the best of toothbrushes can't get around that round structure of the implant very well. You can use things like soft picks that go in between the teeth, work really nicely. Also, you may have them rinse them out whenever they have problems. You can go in with an implant Cavitron tip with a specialized tip on it. Or what's even better is sometimes you can use an air polisher to clean around those should you need to. Piezos have different types of scalers that you can work that the tips are made of titanium, which then if you have calculus or cement, which is one of the side effects sometimes of having a cemented restoration, is if you leave cement in the area, you're going to have problems. It can cause that implant to fail. And reinforce plaque control, home care. In that first few years, you should really take a radiograph every year to make sure that the implants are doing well. And then maybe every other year to make sure that the radiographs tell you that the implant is stable. If it's starting to have a problem, go back to that CIST and look at what we do to stop its progression from getting worse. Okay, so I've covered a lot of things you have to think about. I know it's been a lot. If you have questions, you can either open mic it and I'll be glad to answer, or you can do it in the chat as well. Either one is acceptable and fine for me. If you don't want to, either way is acceptable. If not, I hope you've learned something. I hope that I've provided you with some helpful insight after doing implants, placing implants for 30 years. I teach the residents how to do it, and by the time they leave in a year, they've placed most of them 30 to 50 implants. So, and they know how to treat the problems too. Do you have any questions at all?
Hello, if you do have any questions, please raise your hand up and I'll hand over the microphone to you if you want. Dr. Kesiena, I know you are an maxillofacial surgeon in Port Harcourt, Nigeria. Do you have a question? I would allow you to speak. You're allowed to speak, Dr. Kesiena, if you want to. Go ahead.
Hello.
Hello,
Hi.
Can you hear
Yes.
me?
we can hear
Good
you.
evening. Hello.
Yes, go ahead.
Hello.
We can hear you. Go. Do you have a
Oh,
question?
okay, okay. Thank you. That was such a beautiful presentation. I just have a quick one. It may sound I hope it won't sound silly. Remember, I'm an oral surgeon or a maxillofacial surgeon. So, how do you, when you do your immediate implant, when you load immediately, how do you take out the occlusion? Do you reduce the length of the crown, or you put like a bite block?
Yeah, it's a very good question. No, it's not a silly question at all. You take it completely out of occlusion, and then even when you're forming your interproximal contacts, you make them very, 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 very light. And obviously, you're going to need to inform the patient that they have to be careful to clean out between there because, we know that as a periodontist, I know if you have an area that has food impaction, that's going to cause problems, isn't it? But you want to make sure that there's no micro movement. So yeah, you don't have to make the crown shorter, but wherever it occludes, and that's usually, in the cingulum area or just in the lingual area of that crown, you reduce the occlusion so it's basically non-existent. And in doing so, if the patient understands that, it can work very predictably. I've done, hundreds of these.
Okay. Thank you.
All right. If we
Hopefully.
have more questions, please do ask. We do have the permission of the professor here to share the slides in a PDF format. So if you would like to receive that, we want you to send us an email. I'll put that email on the chat right now, and I will email it to you in the next couple
Yeah, I
minutes.
have
But
actually two different types. You can have it as a handout formation, or you can have it as the actual PDF of the slides, and you're welcome to use them however you want. I don't, at this point in my career, I'm probably about a year out from retiring, so you can, anything that you want to use of mine, you can use.
Anyway, thank you so much. You know, one question. One of these days, I think we need to bring you to come with us on a course in Nigeria. We are hoping that to be able to bring most of the dental schools together, where you will be teaching the professors in each. There are about 12 to 15 universities in Nigeria, and we are hoping to inculcate implant dentistry in the undergrad. Maybe one day we could.
Yeah,
Talk
that'd
you
be
into
fun.
traveling to Lagos or Enugu. Enugu is they're very enthusiastic and very open to implant dentistry. Yeah.
Okay, yeah, I'd be glad to do that. That would be fun.
Okay. Anyway, thank you so much. Thank you guys for attending. If you
So
get
it
back
looks
to
like,
us,
hey, Dr. O, before you go, it looks like someone put that they would like the materials. And did you get that one? It's Luther
yes,
3. Okay, very
yes,
good.
Lucky, yes, yes. And all the attendees, you know, what I'll do is that I have all your email addresses from your registration. So for everybody that attended today, if you would want to just send me a message and we would get it across to you. It is, yeah. Thank you so much, Dr. Reeves. It's been a great one. Did you talk about corticosteroids at any point during your presentation?
I did not. And it's interesting, even NSAIDs, some people, and I think Dr. Cassinia has another question too, which I'll be glad to answer. With
Okay.
steroids, steroids, if you go, I teach a lot of different courses in hygiene. I teach pharmacology, I teach periodontology, I teach laser therapy, I teach, nitrous oxide sedation, local anesthesia. So I get the advantage of really having to review that stuff every year. So steroids are good. And if you remember back in your pharmacology, how the arachidonic acid pain pathway, whenever you have tissue damage, what happens is you have two different pathways. You have either the cyclooxygenase pathway or the lipooxygenase pathway. And as you do that with the steroid, you block it very early on, which then decreases the amount of things like some of the thromboxane A2, a lot of the different prostaglandin E2s, all the different things. But also, as you do that, you inhibit somewhat the bone capabilities for formation. In
Mhm.
fact, I'm having my shoulder replaced in May, as you know, Dr. O, and they've already told me a week prior I cannot take any nonsteroidal anti-inflammatories, because of the fact of the way that in some nonsteroidal anti-inflammatories will inhibit some of the bone cells that actually will be needed for the osseointegration. In dentistry, we've not really considered that. And I've looked at that and I've thought about that. But, there's something to be said about pain control. And as I mentioned, the combination of an NSAID plus Tylenol is very, very powerful. With NSAIDs, a lot of people use narcotics, and I always say narcotics don't really help control the pain. They just help control that you don't care that it hurts. And so I don't use a lot of steroids. I haven't now, unless it's like a soft tissue pathology like lichen planus or pemphigus or benign mucous membrane pemphigoid or something like that. And then in that case, I might use some topicals. When it comes to systemic steroids, I'm very, very cautious about that. Even if I'm doing a sinus lift, some people would say using Flonase, which is a steroid. Basically, they don't advocate doing that. I still do for that one, but for any types of regular surgeries, I rarely will use steroids.
All right. Thank you so much. Any more questions, Dr. Ksenia? Do you have a question?
Yes, I do.
Yes, go ahead.
All right. With the immediate implant, he said you should make it 3 millimeters more apical. then make it a little more palatal. Why do we have to make it more palatal? And what if you don't have adequate bone on the palatal surface?
So if you don't have the palatal bone, remember I said at the beginning, the facial plate determines the fate during the procedure. If you don't have the palatal bone, you can't do it. But the palatal bone is going to give you that immediate support that you're going to need. So as you go apical, 3 to 4 millimeters, what you're going to see is that you actually hug that palatal wall. Because most of the time, if you think about it, the round implant is never going to be the same size as a tooth, particularly if you think about the central incisor, right? So if you placed a 5 millimeter implant in the central, you might be able to get close. And then your question goes, well, what about the facial that has a gap between the implant and the actual facial surface? And I will tell you that almost all the time I will put some bone grafting material in there. So the palatal wall gives you that support that you need to give it that initial stabilization, coupled with the placement apically. If you don't have enough palatal bone, then you have to graft and you come back. That's the key. So that would be not one I would do that as immediate placement.
Thank you. Thank you very
Sure.
much, sir.
All right. Anyway, thank you. And thank you so much, guys, for joining. I know it's about past 9 p.m. in Nigeria. I see someone from Iraq here. Dr. Zara, are you still there? I noticed someone joining all the way from Iraq. I don't know if you are
Wow.
in the United States now, but we have a lot of doctors all the way from Nigeria, from many from the different zones in Nigeria are well represented here, and hopefully we'll be returning to Enugu and Lagos very soon to continue our implant classes. But thank you so much, Dr. Reeves. It's been a
Sure.
pleasure having you on this, and looking forward to a part two one of these days.
Very good.
Well, all right. All right. Thank
Thank you,
you,
Dr.
and
O. Take care
have
now.
a wonderful rest of your day.
You too.
All right. Bye-bye. All right. If anybody wants, we do have a few minutes here to catch up if you are interested. We do have some implant products, MSDI, that we have currently available in Lagos. And if you're interested in starting your implant, implant work, we'll be willing to support you. So reach out to us, and we'll make sure that happens. Dr. Kasena, looking forward to some cases together in Port Harcourt as soon as I know that a lot of people want implants. Bone is also an issue in terms of. Um, I just want to ask Dr. Kasena, where do you guys get your grafting materials from?
I get mine from Lagos. I have two
Okay,
suppliers.
okay.
Yeah.
I guess we'll have to be in touch. So it comes with they deliver membranes as well.
You have to buy membrane separately.
Okay, from the same supplier.